Hi everyone, I'm Danielle Matias here at Caring Medical Florida. Today I want to talk to you about carpal tunnel syndrome, which is actually one of my favorite things to treat in the office as related to wrist instability and wrist pain. So for those of you that may not know, carpal tunnel syndrome refers to when you get a median nerve entrapment. So that's the nerve that runs here through kind of this wrist and through the palm of your hand and feeds your first three fingers and then part of your ring finger. So people with carpal tunnel syndrome oftentimes complain of numbness, tingling in those fingers. Maybe it comes and goes, it's a little bit more intermittent, or as it progresses becomes more and more constant. So here, this is just kind of a cross section of your wrist. Okay, so this is that carpal tunnel. That's where that median nerve is. There are a bunch of tendons, that run through that carpal tunnel as well, and some blood vessels. And it sits kind of right on top of these wrist bones here. So again, when people get carpal tunnel syndrome, this is kind of the area that's shaded in blue where they are the most symptomatic. There are physical exam tests for carpal tunnel, so people can do, you can even do this at home. You do this Phelan's test where it's kind of like an upside down prayer, okay? Hold it 30 seconds. If you start to get numbness, okay, in any of your fingers, that actually is indicative of carpal tunnel in that hand, okay? You can also tap on the nerve, like if you just tap on that median nerve and you get kind of zingers or kind of jumpy, that also can aid in the diagnosis of carpal tunnel syndrome. In our office, other things that we look at in somebody that's complaining of these symptoms is the wrist and how stable the wrist is, okay? So if you think about where that median nerve is located, I'm just gonna back up really quick. With that median nerve being in such close proximity to these bones, let's say somebody has a wrist instability, all right? Let's say they have some ligament injury that's allowing those wrist bones to move more than they should. Well, that nerve lays right there. So it wouldn't take a lot for those bones to just, shift a little bit out of place and start whacking on that nerve, causing symptoms and causing nerve injury. So part of what we want to do in the office is, let's see, does that patient have a wrist instability? Is it, mild, moderate, or severe? Can I just, with a little bit of force, minimal force, can I, move their bones a lot in their wrist more than they should be? If so, if we conclude that that patient has wrist instability, that really is part of the treatment plan in resolving the carpal tunnel syndrome in the office. Other things, aside from carpal tunnel syndrome that can be related to wrist instability, and oftentimes we kind of see a lot of these hand in hand in the office, is the patient might also have tendon degeneration, okay? So again, there's a lot of tendons that lie in that carpal tunnel, a lot of tendons that surround that wrist. So if there is instability that's causing a nerve issue, all of those tendons can get overworked as well. And I call them overworked and underpaid tissue, right? Like they're working so hard trying to stabilize the wrist that they start to break down themselves. Thumb arthritis. This is another one actually that is related to carpal tunnel syndrome. So people that get arthritis, ligament injuries, instability progressing to arthritis in the base of their thumb, that too, that extra shifting can also cause excess irritation on that median nerve. Very closely related as well. Ligament laxity, like we're talking about, and just overall joint degeneration, all of these can all kind of, be brewing over time and happen in someone with wrist instability and carpal tunnel syndrome. So when patients come in, we're going to do an ultrasound, okay? And we're going to do, obviously, a physical exam, but the ultrasound is going to be able to show us several things. One is, can I see if there are ligament injuries and excess motion in the wrist, okay? What does that median nerve look like on ultrasound, okay? Is it this bright white kind of honeycomb shape that's pretty classic of a healthy nerve? Is it not bright white? It's losing its color. It's swollen. When I measure it in the forearm and in the wrist, what's the difference, right? So people with carpal tunnel will actually typically have a bigger, kind of more swollen nerve in their wrist. So we can measure it there, follow the nerve, measure it in the forearm, and look at the ratio between the two to see if it's diagnostic for carpal tunnel. Sometimes too, we can actually even do dynamic x-rays of the wrist, right? And just see if there are bones that are moving more than they should when the patient waves their hand or moves their wrist on x-ray. The elbow is another thing. People can have what is mimicked as a carpal tunnel, but really it's coming from elbow instability or elbow ligament referral. So that too could be part of our evaluation. Let's say we do all these tests and they have some instability. Well, obviously we want to do prolotherapy to tighten the ligaments and restore the stability. That's step one. Let's say, they do have a wrist instability and we see that that median nerve is also swollen and it looks like it's injured on ultrasound. Then we want to see, okay, is the nerve stuck? when I try to kind of move the wrist, does that nerve just kind of stay put, or does it move the way that it should? So let's say it's mobile. We still do want to continue with prolotherapy to get the wrist stable, and then we might want to consider doing like a hydrodissection, or where we actually, look at that nerve on ultrasound and inject maybe a 5% dextrose or PRP around the nerve to get it to heal. Let's say we look and the nerve is not moving, we'll probably be more likely to start with hydrodissection versus adding that at another time. Now, all of this, of course, is dependent on the patient, right? We treat patients, not just strict algorithms. But in general, when somebody has symptoms, like let's say they have carpal tunnel-like symptoms, but they come and go. They're not constant. They're just kind of, every now and then. Well, obviously, step one is always to correct the instability if it's there. And if we can get the pressure off the nerve and the nerve bounces back and heals on its own, fantastic. The more constant the symptoms become, the more they affect patients' function, their ability to do things, then the more likely we would maybe consider doing hydrodissections as a part of a first-line treatment. All that is patient-dependent, though. Let's say someone comes in and it's a pretty severe case. Like maybe they even had an EMG, which is a nerve case, and it's pretty severe, and they're starting to get muscle atrophy. Okay, so like the actual muscles that median nerve help feed are starting to die because they're not getting nerve impulses. Nerve things we take seriously, right? There absolutely are times where patients might need surgery. And I've had to do that. I've had to tell patients, as much as I would love to help you, we really need to have a surgical intervention here based on how severe it is. We talk about true carpal tunnel syndrome and then what we call pseudo carpal tunnel syndrome. Okay, so pseudo carpal tunnel is patients, they have that numbness, maybe in those fingers, classic carpal tunnel, but let's say their Phelan's test is negative, their Tunnell's test is negative, maybe they had an EMG that was negative. Maybe we look at on ultrasound at their median nerve, we're like, this is beautiful. Like your median nerve looks fantastic. It doesn't look like there's any injury there. Maybe they also don't even have a wrist instability, like their wrist is stable, but they still have these symptoms. That would actually kind of clue us in to kind of travel up more and look at the elbow, because ligaments have their own referral pattern and they can mimic some of these nerve conditions sometimes. So if somebody has an elbow instability, really tender at all these ligament attachments, we see injuries on ultrasound or excess motion. In that case, that patient would likely need prolotherapy to their elbow, not necessarily to the wrist or that median nerve.